I'm professor of medicine at the College of Medicine, Penn State University in Hershey. I would first like to thank Dr. Brokop and the organizers of this meeting and the Brock Ethics Institute for inviting me to participate in this remarkable conference. I'm truly honored to be among this gathering of distinguished international scholars. I'm a practicing physician, a hematologist with lifelong interest in religion, history, and bioethics. It's a privilege to be among the panel here this afternoon. I want to thank every one of you gentlemen for taking time to be here to share with us your thoughts. I would like to remind you that each one of you has 15 minutes. And at the end of your presentation, I will make brief comments on each one of the presentation. And then we will take questions at the end of that, since the topic that will be presented are interrelated and there will be themes that will be repeated in the presentation. Let me first introduce our speaker, the first speaker today, Imran Rafi Punekar. Mr. Punekar graduated from Villanova University. Currently, he is a Fulbright student fellow at the Faculty of Medicine and Public Health Services in the United Arab Emirates. He intends to apply for an MD PhD program. His topic today is the necessity and obligations of cultural competency in the physician's relationship with the Muslim patient, effects on the quality of healthcare.
Thank you. Assalamu alaikum. Thank you for the introduction, and also thank you everyone for coming. And great thanks to Dr. Brokop and for everyone who helped organize this wonderful conference. So I'll go ahead and get started. There we go. Okay, so some of the things that I want to talk to you really quickly today, and this will be a brief sort of primer into cultural competence and some of the issues that I see as relevant in the discussion of cultural competence related to the treatment of Muslim patients in the United States today. So briefly, I'll define cultural competence, some of the challenges as related to Muslim patients, and also outline a skill set that can be applied to cultural competence, and give you 3 case studies that outline each of the skills in that skill set. So this will be my helper, and you'll see him pop up later on. But at the end, of course, I want to leave some time for questions and a bit of discussion. Okay, so what is cultural competence? And there's several definitions about it, but I'm sure that most of you here have a pretty good understanding. Anyway, the way that I define cultural competence is that cultural competence is the ability of the physician to transcend differences in culture, language, beliefs, and values in the patient-physician relationship in order to ensure that the integrity and obligations of that relationship are maintained. And of course, this isn't anything easy. It's rather challenging, and it requires specific training, also reinforcement and retraining in theory and also in the active clinical environment. So cultural competence is arguably grounded in the idea of the fact that an adequate level of healthcare is a right of every individual, and its provision is a responsibility of society. And as a result of that, cultural competence becomes necessary and mandated because of the requirement to provide just and beneficial healthcare to everybody. Because if you have cultural barriers which are impeding the provision of healthcare, in order to ensure the just and beneficial provision of healthcare, you have to implement cultural competence to make sure that the healthcare that is being provided is provided evenly and equally to everybody. So some of the specific challenges of cultural competence as related to treating Muslim patients in the United States. One of the big ones, of course, is the general unfamiliarity with Islam in America and also in the American healthcare system. The second one, and this is probably the most confounding factor, is the great diversity of American Muslims. And you see diversity on very different planes, and these include cultural diversity, linguistic, religious, religiosity, socioeconomic, and even geographic diversity. And another thing that is particularly relevant to this discussion is the fact that there's no real central spiritual authority or sort of center for guidance where Muslim patients or even American healthcare providers can go to in order to figure out or find out, what certain positions or what treatments may be permissible or not. So what tends to happen in this kind of situation is that a lot of people who are coming from very different cultural backgrounds, because they don't have a central authority or sort of a dedicated guide as to how to make decisions, they'll tend to fall back on cultural practices. And in extreme cases, these cultural practices may actually be not in line with Islamic teaching at all. So another key concern in bioethics is the patient-physician relationship, and this is sort of the focus of bioethics. And you can arguably say that all bioethical principles come out of respect for the patient-physician relationship and the obligation to maintain the integrity and the duties of that relationship. So conceptually, the problem that we face, I take this quote from one of our attendees and presenters who's here today, but the problem that we face conceptually is that Muslims' attitudes to both types of ethical issues, and this includes general and also those ethical issues that are specific to Islam, often prove that pragmatism prevails, and the aim is to seek compromise between Islamic heritage and the achievements of modern medicine as long as basic Islamic dogma is not violated. So basically, we want to arrive at some sort of agreement where we have concordance between Islamic heritage and also the realities of the modern healthcare system. But the way in which we do that can differ ideologically and also practically. That's actually just a picture of some mountains in Oman, which I climbed a couple of months ago. So what I want to advance is a sort of a three-tiered approach to cultural competence, and I want to argue that there's different levels of cultural competence and that these sort of build on each other. And the first two we've talked about many times over today and yesterday. And number one, of course, is just cultural awareness and cultural sensitivity. And this means, on the physician's part, being able to listen to the patient, being able to analyze the patient based on who they are and their background. Also, this could include knowing something about the culture of the patient, although, as many people have reinforced, we want to avoid stereotyping patients. The next tier, or the next sort of step in cultural competence, is being able to engage the patient or the family or decision maker on their own terms, and that means with respect to their religion. And this allows you to actually have a dialogue and bring about changes in decisions, or bring about decision making that's amenable to both parties. So, and one of the big points of this is that it's not very easy, and a lot of times you need resources that are provided by the institution, such as interpreters or chaplains, for instance, which can be a great aid in facilitating this goal. And the last one is being able to appropriately override culture, and when is that appropriate, and how would you do that in a sensitive manner? So I'm going to present 3 case studies which are not that complicated, but hopefully will illustrate each of the tiers of cultural competence skills. So the first case is that of a Muslim couple that comes to a physician concerning their ability to reproduce. The doctor offers various solutions, including IVF and hormone therapy. Sorry, I have to rephrase that. The doctor offers several solutions, including ovum and sperm donation, as well as the use of a surrogate mother. However, none of these options are of help to the couple, and the physician notices that the couple seems to be very distraught by this. So, for instance, what would ideally have happened in this situation? What you'd want to see is just for the physician to be a little bit culturally sensitive, and maybe even ask the patients, or the parents in this case, as to what do they believe. Are there any religious components to the decision-making process for obtaining treatment for assisted reproductive technology? And so, for instance, he may find, and of course he has to remember that this may differ from one patient population or one specific patient to another within the Islamic heterogeneous society. But generally speaking, he may find that Islam does not permit reproductive strategies which include sperm, ovum, or the uterus of anyone outside the marital relationship. And so in this case, it would help if the doctor had sort of kept this in mind and also advanced other strategies which would be in keeping with Islamic tradition, which include in vitro fertilization and hormone treatment. Sorry. Okay, good. Okay, so the second case study is a bit more complicated. In this case, you have a Muslim couple who have just had their first childbirth, and congratulations, they have twins. Unfortunately, the birth is premature and perhaps due to familial ties between the husband and wife, which is something that is rather common, especially in the UAE, and as far as I've seen. The children are born with severe congenital defects and under severe neonatal intensive care. Now, the prognosis is not good, and the physicians want to approach the parents about the possibility of issuing a DNR for these children. So one of the things that we've seen in some of the literature about DNR or the use of DNR in Muslim patient or for Muslim parents or in Muslim communities is that the majority of patients or parents will actually disagree with using DNR outright, and there are some cases in Oman and Malaysia which show that the vast majority of Muslim parents didn't want to use DNR, didn't even want to talk about it. So, and the slight variation of this case is if the parents do refuse the DNR, and then one of the children is pronounced brain dead, but is being kept alive artificially on ventilation or artificial hydration, then how would you go about talking to the parents about the next step and what the best thing to do would be for the sake of the patient? So in this case, what you really need to do is not only just be culturally sensitive, but now that you realize that there's a disagreement between the patient and also the physicians, is to be able to engage the patient. And a great tool that would be very useful in this situation is to have a Muslim chaplain who can come in and talk about DNR, who can talk about futile treatment, and also reconcile, because in this case, the patient or the parent's argument is going to be based on the belief in the decree of the Almighty God, and that no one else can decide when life ends. But religiously speaking, you can reconcile that idea, and still in respect of it, say that there's a certain point at which death is inevitable, and that prolonging life of a patient is unnecessary and actually not beneficial. Sorry. Okay. So case C is pretty simple, and it's you've probably heard of it before. It's happened in several countries. But a Muslim woman is rushed into the hospital after entering labor. Her husband, upon seeing that she will be treated by a male physician, requests a female one. However, there is none. The husband insists that his wife be seen by a female physician only, or not be seen at all. And the hospital staff eventually treat the woman because it is an emergency case. So in this case, you've got a clear instance of disagreement between the family member and the physician's role, and also the obligation to provide care in case of an emergency. So it would be nice if just being culturally sensitive and also engaging the patient or the family members could solve this issue, but there may be a point where it becomes necessary to be able to tactfully override inappropriate requests for treatment, especially when they conflict with duties or the integrity of the medical profession. So one example, and we've talked a little bit about this over the past 2 days, and especially with the movie last night, is the issue of truth-telling. And I just wanted to present one very interesting article that I came across about truth-telling to cancer patients in Lebanon. And in this study, they split up physicians into two categories: the truth-tellers and those who were non-tellers. And so these are people who, in the majority of cases, told their parents about their diagnosis of cancer versus those who did not. And interestingly, what they found is when the physicians were asked, if you had cancer, would you want to know about it? 99% of the non-tellers said that they would want to know, whereas 70% of the tellers said that they wouldn't. And so I thought this was rather interesting, and I wanted to look at why this might be the case. And if you look at the article, it's Hamid et al. In 1998. But they found that there's two significant factors that influence truth-telling versus non-telling, and these include the type of specialty as well as length of clinical experience. And so basically what this means is that truth-telling is not something that's easy. Diagnosing bad or delivering bad news to a patient is something that's very difficult. It takes training and it takes practice and experience. And those physicians who were in specialties which involved more communication or more interaction with cancer patients and therefore more breaking of bad diagnoses, and those who had more clinical experience were the ones that were more experienced and also were more comfortable and more able to deliver bad news and decide when it was appropriate to do so. And so what I want to say here is that this is just another sort of skill that needs to be learned and needs to be implemented. Really quickly, I'll just say that, you know, while there's a huge onus on the physician and the healthcare providing population to be culturally competent, there's also a side of that which lies on the patient population. And so the patient population needs to make sure that each patient is educated, knows about healthcare treatments and options and their own position and points of view. And this, of course, expands not just on each individual patient, but also on professional organizations, for example, such as the Islamic Medical Association of North America, which represents a collective minority population. Right now, so I'm looking at my Fulbright study is focusing on the status of end-stage renal failure patients in the UAE and their options for treatment. And here's my contact information. I'd love to hear from any of you guys. Oh, it's that one. Sorry. Okay. Sorry. So here's my contact information. I'd love to hear from you guys, and thank you very much.
Thank you. You're welcome. Our second speaker is Dr. Faiz Khan. Dr. Faiz Khan is an assistant professor of emergency medicine at the Penn State University Hershey Medical Center. Dr. Faiz Khan graduated from the Albany Medical College, and then he joined our institution only 8 months ago. Dr. Khan is a member of the board of the Asthma Society for Islamic Spirituality. He has served as a panelist on the United Nations Committee dealing with spirituality and interfaith issues. His topic today is faith and care of the patient, an Islamic perspective on critical illness and death. Dr. Khan.
Thank you. Thank you, Dr. al-Mondhiry. I remember bothering Dr. al-Mondhiry from the ER. That was my first interaction with him, harassing him from the emergency room for a consult on a hematology case, but it's finally good to see you in person. First, I'd like to thank Jonathan Brockup for accepting the proposal in the paper, and two apologies. Number one, an apology for the little bit of lethargy and shakiness in my voice. I pulled in here at 2 in the morning last night after an ER shift, and I was still kind of piecing together my presentation upstairs. And number two, an apology for those of you who tortuously read the draft. It seems a little flighty, and the finished product is a bit more lucid, and I hope for those of you who are inclined, you'll enjoy it. So what my topic originally was a talk I had given at St. Vincent's Medical Center about faith and care of the patient, and they just wanted a real bare bones understanding of Islam and how it relates to certain perspectives of illness. And in researching the material for this presentation, there's a lot of major intersections here, and it's been quite a challenge to keep it together and not let it inflate into some huge treatise. So what I thought I'd do is just very quickly, since I only have 15 minutes, just sort of take you through a tour of the issues and concepts and terms that come up and just give you food for thought, and maybe during the Q&A we can have more of a discussion. As my colleague from Hershey, the bioethicist, said, that spirituality in health and illness is a hot topic. Pre-1999, you don't see much in the medical literature, perhaps in the bioethical literature you might, but in the medical literature you don't see much about it. And there's this huge skyrocketing of articles that are not just statistically designed to give you data from a medical point of view, but they're descriptive studies. They're not quantitative studies, and that was a barrier between getting this stuff into the medical literature, the methodology of concluding. So these are descriptive studies written by bioethicists, not by MDs, and there's this huge skyrocketing. But at the same time, the question is, how do you define spirituality? Okay, faith, spirituality, how is it defined? And it's challenging to try to come up with a definition, but this whole issue was a real concern because it has clinical significance, it has prognostic significance, a patient's spirituality has resource utilization significance. All right. Sometimes people that are religiously inclined tend to use resources where doctors think that the case may be medically futile. Other times, patients are very quick to disengage from interventions because of religiosity. So you can't really make a blanket statement about that. And that's not a denominational phenomenon. That is a pan-denominational phenomenon. So how do you define it? How do you measure it? Okay, how do you measure spirituality? What do you base it on? And what are the criteria? And if you read the literature, you see a lot of clustered type of terms: sense of control, peace. Some literature use an ability to bond and connect with music or the environment, coping, healthy coping, overcoming death anxiety. Okay, all these things are clustered around what it means to be psycho-spiritually healthy. Of course, from the etymologic and linguistic standpoint, these are just psychological parameters and indicators. These are psychometric assessments. Okay, and what I sort of like to do is give you. Oh, is spirituality related to religion? There's a huge disconnect. Does religion have anything to do with spirituality? Can you be theistic or non-theistically spiritual? Okay, and to sort of understand these terms, I like to sort of take the linguistic approach. Latin, of course, spiritus, right? The Semitic language is ruh, right? Greek, pneuma. And notice the Greek term psyche. Okay, psyche does not mean mind. Psyche has nothing to do with brain in the original sense of this term. Psyche actually is the equivalent of nefs in Arabic, which is soul. So somebody who's spiritually healthy has a nefs that is normal, stable. Okay, and an index of that stability is the ability to cope with difficulty in trial. And that's essentially how you can sort of explain these things in Islamic, Arabic terms, the language of Fusha, of Islamic liturgy. That raises a whole other set of questions. Is it possible to be psychologically stable but not spiritually healthy from the traditional religious point of view? Right? Is it possible to be psychologically stable but not be spiritually healthy? Hence, score well on the spiritual assessments that nurses and caregivers give out, but still from a traditional point of view still be spiritually unwell? And the answer to that is yes, from the Quranic perspective. It's easy to cope with difficulty and trials and hardships, yet still be spiritually not healthy. Okay? The Modernist Myopia, this is what I call the Modernist Myopia. If you read the literature, there's a cluster of authors known as the traditionalists, and they're from the Christian tradition, the Buddhist tradition, and some from the Hindu tradition and the Islamic tradition, and they talk about this deracination that modern thought has of trying to take terms out of context, and hence to define spiritual health from the notion of psychological stability is an error from if you keep with the metaphysics of authentic religion, because that's just some things that I sort of talk about in the paper, and I'm not going to go into detail right now. Let's see. Okay, so we have to define it somehow. Yes, from the traditional Quranic perspective, to pursue psycho-spiritual wellness is to develop a psyche which is pleasing to divinity. That is the closest Quranic definition to psycho-spiritual wellness. Okay? Does everyone understand that the spirit and the psyche are two different entities from traditional thought, traditional metaphysics? Okay, it's very important to understand because that's modern authors often conflate the two. All right. So this is probably the most neutral definition you can come up with. The psycho-spiritual wellness, pursuing faith in the context of critical illness is, I'm not going to insult your intelligence, but it has a sacred and transcendent component to it. I'm not going to read word for word verbatim, and may or may not lead to or arise from the development of religious rituals and the formation of community. Okay, that is from the medical literature. Okay. Now, is there convergence and divergence if you come at psycho-spiritual wellness from a purely secular humanistic perspective versus an authentic traditional perspective. Is there convergence? Well, yeah, there's convergence. Both sort of encourage what we can call the horizontal dimension of psycho-spiritual health, the clinical benefits like we talked about, the mind-body connection, psychological stability, coping methodologies, being at peace, cooperating with care, not ruining your interpersonal relationships. All of these things are measured when it comes to an index of spiritual wellness. However, what this suffers from a traditional perspective is this: to validate religion exclusively based on efficacies within the perceivable spatio-temporal domain. In other words, this utilitarianization of religion based on secular indices. Okay, and to see value in religion just with that, and I'm going to get into trouble saying this, but this is highly characteristic of the third world Western educated intelligentsia. A lot of these reactionary neo-colonialist writers, post-colonialist writers, in an effort to try to validate religion in whatever context, would try to define it in X or Y or Z ideological terms. Okay, so we have this phenomenon happening again. People say, yes, religion is good because it offers X and Y and Z. Okay, fine. The traditional Islamic perspective has no problem with that. However, a traditional Islamic perspective, which represents most traditions, almost all traditions arguably, there is a vertical dimension to things. Spiritual wellness is an issue post-mortality. Okay? And from the religious perspective, you must insist on maintaining a holistic understanding of religion. Because to deracinate it is an error if you're going to talk about it on its own terms. And again, religiosity possesses more than just ethical moral efficacies. Religiosity possesses more than just psychological equilibrating efficacies from the Islamic perspective. So turning to historical stuff, there's definitely been a neglect and a reemergence of psycho-spiritual health, this whole notion of faith in the context of illness. Okay, what types of resources can faith give a patient? And why do patients feel like they're not supported in this way? Okay, contrary to the ideological intent of trying to keep religion out from serious study, from whatever arena, patients want to be supported psycho-spiritually. So from this perspective, it's an ethical imperative, okay, from the clinical perspective, and from the supraclinical or vertical perspective, it's also an ethical imperative to allow a patient to pursue this wellness. And my paper talks about the ideological and educational roots of this neglect. Okay, why do patients feel that the medical system is impersonal, spiritually impoverishing? Okay, because this leads to choices. People choose not to visit hospitals in the third world and also in America. The data's out there. They'd rather go to somewhere which is nourishing of their spiritual values or reminds them of the sacred, rather than deal with an impersonal institution until it's too late, until their child's appendix ruptures and becomes septic. And this whole thing is, again, driven by patient-centered wellness. This raises boundary and propriety issues. At what point are you imposing religiosity on a patient? At what point is a patient imposing religiosity on you as a physician? From the Islamic perspective, there's no re-emergence necessary because ontologically speaking, and the historical data is there and still there, that religion was always sort of part of the healthcare picture in a pluralistic fashion. So in Cordoba, if you were sick, you had a sacred pluralistic ambiance that would not alienate somebody religiously if they were to be treated by Maimonides or by Ibn Razi. Al-Razi, sorry. Okay, quickly, the divine mandate to suffer, the divine mandate to comfort. Divine mandate to suffer, it's an existential dilemma. Doesn't sit well with modern sensibilities, but I'm sorry to say the Hindu tradition, the Buddhist tradition, and the Abrahamic traditions all say mortality, mortal life is going to involve some suffering. It's the way you deal with it that's going to sort of make you or break you, okay? Trial and affliction in the Islamic context. The differential diagnosis of a bala, right, or a musiba in the Islamic tradition is either atonement or a blessing in disguise. Essentially, if you want to look at it in those broad categories, okay? It gives you a chance to actualize sabr, which is patience, perseverance, which is a very potent spiritual vehicle. The term sabr is mentioned numerous times in the Quran as being able to allow psycho-spiritual wellness. Qabd and bast are technical terms. from the Islamic esoteric tradition, qabd being a moment of constriction and difficulty, bast being moments of expansion and elation, both having to do with misfortune and fortune, both having potent value. And all of these concepts have Quranic and Hadith-based affirmations, which are in the letter in my paper. Illness is remembrancier. I'm going to ask you to duck. Illness is remembrancier, the mudhakkir that musiba is, right? It counters a lot of psychospiritual toxins. All right. The Quranic complaint against humanity is that it tends to wrap itself up in what's called ghafla, heedlessness of what's important. And difficulty, affliction, trial is seen as a correction of that. Okay. And of course, kibr, arrogance. Human beings have a sense of ultimateness. Okay. And sometimes when we're afflicted and we're sick, we kind of deflate those spiritual toxins. Dhikr al-maut, remembrance of death, is highly meritorious despite the vulgar distaste for mortality that characterizes pop culture. It's not the same thing as seeking death, but being at peace with death and realizing that it's a transition is something very encouraged in the Islamic tradition versus the death anxiety of modern pop culture. Life is transient and life is terminal. You know, this whole notion of terminal illness is very sort of oxymoronic because when you're born, it's terminal. There's this overriding sense of terminality. If you read the Quran, you know, the Quran is pregnant, as they say, with the hour being the macrocosmic resurrection and the microcosmic resurrection affiliated with death. Okay? So, you know, you can't really get around these things. These are in the consciousness of a traditional Muslim. Okay, comforting the sick, obviously very highly prioritized in the Sharia and the adab and the akhlaq of Islam. Sharia does not mean legalism. Like, annoyed when it's translated. The Sharia means it's the amalgamation of dharma and religious law. Dharma meaning the path or code of conduct, which involves not just legalism, okay, but involves methodology of behavior. Okay. And again, the paper talks about explicit stuff in the Quran, the Hadith about that. Clinical scenario, and I'll leave with this. Patients desire it. The literature fully supports that. They want to have spirituality and religion as part of their clinical encounter. There are institutional initiatives, the spiritual screen, the spiritual needs assessment. These are institutional-driven agendas now at this point because of the recognition that this is important for patients. The balance, again, between facilitation of someone's psychospiritual pursuit during illness versus imposition of that. Okay, the paper talks about that. Now, the MD has been called out. All right. Now, when you're a doctor, you're either a hakim in the traditional Islamic sense, like Ibn Sina or Maimonides or Al-Razi or Ibn Nafis, who can converse in pastoral care and psychospiritual support just as easy as they could in physiologic support. Or, from the allopathic context, you are a niched-off functionaire automaton dispensary of a particular allopathic skill set. Okay? Which are you? You know, that's something that perhaps the scale needs to be moved more over to the hikmah side for physicians. Yes, 1 minute. Okay, great, thank you. It has been neglected by doctors, this whole notion of pastoral care, some kind of pastoral care for the patient. It's welcomed by patients. Patients actually want their doctors to inquire about their spiritual pursuits and even engage them in discourse. There are fruits of this, deepening of the therapeutic relationship. There are problems with this. A lot of physicians that are trained under modern allopathic curriculum are just uncomfortable with this. Due to competency issues, they're uncomfortable with their own beliefs, and that sort of keeps them from pursuing this. And there is a minimal role, however. Most studies will say that you need to include a spiritual assessment as part of your history taking in a medical encounter. And there are some courses out there that teach clinicians how to become pastors in an ecumenical way. I mean, actual pastoral counseling and intervention. Some studies have shown how physicians pray with their patients, and there's an etiquette of doing that without crossing boundaries, and patients love it. It deepens their relationship with them. And I was going to, well, my personal experience, you can ask me what kinds of encounters I've had in the ER in terms of trying to engage a spiritual and religious discourse with patients. But I'll tell you this, I've never, ever, this effort on my part has never been met with any opposition or hostility from the patient, of the hundreds of times I've done it in a secular society. So I'll close with that. Thank you.
Thank you. Thank you, Faiz. Our third speaker is Dr. Ali Bhai. Dr. Ali Bhai is Assistant Professor, the Department of Medicine and Health Policy Management and Evaluation at the University of Toronto in Canada. He received his master's degree in science and his medical degree from the same university. Dr. Ali Bhai has written extensively on religious ethics and end-of-life care. His topic today is artificial nutrition in advanced dementia, scientific challenges and proposed Islamic ethical responses.
Thank you very much. This is on? Yes. So you've heard me speak before, and I thank you again for this opportunity. This talk is a lot more of a work in progress than some of the previous work we've done, and I'm looking forward to a lot more input and feedback because I'm on much more tentative ground and exploratory ground in this area, at least from the research I've done to date. What I will try and do over the next 15 minutes or so is briefly discuss what are the feeding issues in advanced dementia, what are some of the ethical issues around feeding, where does the PEG tube, the percutaneous gastrostomy tube, come in, and how do we resolve the conflict or the perceived conflict between ethics and medicine, particularly within an Islamic framework, and what challenges remain for us as a group of individuals involved in Islamic bioethics to consider going forward. So first of all, many of the audience are not very familiar with dementia, so I'll spend just a moment talking about that. I'm a geriatrician in my clinical practice, and I see a lot of individuals with various dementing disorders. Dementia is a neurological syndrome. It's characterized by a progressive, irreversible impairment in various areas of cognitive function, memory and other cognitive domains, including language, spatial function, attention, and so on. It affects up to 1 in 3 older patients over the age of 85, individuals living in the community, individuals in nursing homes and other long-term care institutions are even more commonly affected. And at the current time, there is still no treatment that can significantly alter the course of this disease in the vast majority of the patients that present with it. So it's common, it's irreversible, and it robs people of their personhood. In the early stages of dementia, feeding issues come into play because individuals have disruptions in parts of the brain that lead to an interest in food. Many of us, when we see food, have an appreciation of food, we have certain loves for certain types of food. That starts to be lost early in the dementia for some patients, not all. There is a general apathy or malaise and a loss of interest in eating, and sometimes the memory loss can be impressive enough that people actually forget whether or not they've eaten. Some people then tend to eat over and over again and gain weight, but many tend to forget that they've eaten, and if they don't have the appropriate social cues, they'll just start losing weight. In the late stage of the disease, things become much more severe. There is a loss of an ability to eat, something called an apraxia, where people have difficulties with one or more aspects of the feeding process, taking things out of the fridge, opening up cans, picking up a spoon or a fork, bringing food to mouth, chewing, swallowing. Any of those or all of those aspects of the eating process can be impaired without abnormalities like obstruction or difficulties with the actual motor mechanism. It's not a problem with the muscles, it's a problem with the brain. And this is difficult for patients and families, particularly families, to conceptualize. In the early stages of advanced dementia, many patients can be helped with things like social cues. You remind them it's time to eat. You sit down and eat together. You help them to eat by putting your hand on their hand or helping to feed them. And these kinds of things can help early on. However, with progressive advanced dementia, the amount of calories people will take in will decrease. There will be increasing disruptions in their ability to eat. The metabolic rate starts to increase. People start to lose weight because the balance between calories in and calories out shifts. And with increasing malnutrition and weight loss, you get complications and ultimately death. One of the most common causes of people dying of advanced dementia is a pressure ulcer that becomes infected or an infection such as pneumonia. And these things are often contributed to by the malnutrition associated with advanced dementia. So on to the ethics side for a moment. In many societies, there is what I have called and what some others have referred to as the need to feed. And if you stop for a moment and think, there is no surprise in anyone's mind that we would immediately see a need to assist someone or help someone who is unable to eat and whom we feel we can help in eating. It's just ingrained in all of us across societies and cultures. You will find multiple references to this, the need to help individuals who cannot eat. Not in the setting of advanced dementia. I'm just dealing more generally right now. There are perceptions that starvation and suffering are somehow intimately linked, and that one of the obligations of us as human beings to help our fellow human beings is to alleviate that suffering from starvation. And that's considered meritorious, and suffering and the starvation that begins it is considered something bad. Also, debates have gone on in the ethical literature around feeding, again, not within Islam, but more broadly, about whether providing food and water in forms other than the standard things we have at the table, are these considered part of basic care, such as trying to relieve pain and dealing with discomfort and sitting at the patient's bedside, or are they forms of medical treatment? Are they like tablets? Are they like surgery? Are they other forms of therapy? And of course, within certain discourses, for example, within Catholicism, references to things like ordinary versus extraordinary means. And some of you know about recent developments in the Roman Catholic Church and papal edicts that came out before Pope John Paul II passed away. Within an Islamic framework, I will suggest, based on how we might respond to this, that there are two primary ethical principles at hand. The first is the notion of the sanctity of life that we have discussed many a time, and the second is the notion of whether there is a fundamental duty within Islam to feed. So the sanctity of life side of things we're all familiar with. We've discussed this yesterday and earlier today. Let me talk for a moment about the need to feed, or the duty to feed. In the article, I outlined some of the ayat of Quran and some of the hadith that I have found, and these are some of the primary sources. I have found almost nothing to date in the secondary sources and any of the commentaries and so on extrapolating the need to feed into settings of people with permanent disabilities and scenarios including dementia so far. If any of you know of any, please, I would be happy to have them. I'm still looking. The ayat of Quran and the hadith so far have suggested that there is a duty, or at least there is a recommendation at a minimum, that we should be feeding those who are sick, and there is a social duty to the collective ummah to eradicate hunger, and we are responsible, and there are hadith from Prophet Muhammad, peace be upon him, of the notion that we are responsible, for example, for the hunger of our neighbor, or to ensure that we do not go to bed with a full stomach while our neighbor is hungry, and similar hadith to that effect. There's also the notion that this duty encompasses more than just giving them food. It may include, at a minimum, providing them the financial resources if they are suffering from poverty, so that they can obtain the food. It includes, as far as I can understand from interpretations, providing food for those individuals who cannot prepare it for themselves. And it includes, to some component, the assistance with preparation and or the actual feeding process. This is where things start to become a bit more tenuous. A little comic break for a moment, and that is, his last words were, "What'll it do, kill me?" So this is where the issue starts to become a challenge. There are three possible scenarios with respect to feeding tubes. Feeding tubes have been promulgated as a method to try and reverse the malnutrition and the weight loss with advanced dementia, because individuals who can no longer eat for themselves and will combat with you when you try and feed them forcefully by mouth, you can bypass it by having a tube in the stomach. I outline in my article some of the risks and the rationale and the history, but I won't go into that here. There are three possible ethical scenarios. The first is that the feeding tube might prolong life. The second might be that it is neutral, with neither prolongation of life on average, nor does it facilitate or enhance or hasten death. And the third scenario would be that it hastens death. For the first and the third scenario, the Islamic responses are clearest. If we have a scenario where someone cannot eat, for example, a patient has a major stroke and they're unable to feed, but they're otherwise fairly functional, and we know that putting in feeding tubes will prolong life on the basis of at least one randomized trial and some non-randomized studies, the answer is clear. The sanctity of life principle supports that we must do these kinds of interventions and treatments that will prolong life. So even if we consider peg tubes and feeding tube related nutrition to be treatment, it can be administered, and it should be, to prolong life. That's the easiest analysis. If it's a situation where instead it hastens death, and it is considered akin to something that we would do that would harm a patient, then obviously, whether we talk of principalism and non-maleficence, or again within the Islamic concept, we should not try and hasten death. That is in the realm of Allah. Then again, the feeding tube would be something that would be considered inappropriate in that circumstance. The problem in advanced dementia, as I've suggested in my article, is that we are in neither of these situations. There is insufficient evidence to suggest that we can prolong life with feeding tubes, even though it seems very intuitive. People are starving, they're not eating, they're getting malnourished, you feed them, they'll do better. The evidence does not suggest it's that straightforward. At the same time, there is some evidence to suggest we might hasten death, but the quality of that evidence is quite limited and poor and remains the subject of a lot of debate, and there are no high-quality studies. So we are probably in the realm of this third category. And the question now is, what is the most appropriate ethical response? Within Islam, the first duty, the notion of sanctity of life and prolonging life no longer applies, nor does shortening survival apply, and so we're now dealing with thinking about the duty to feed and how far does that duty go. I have suggested in my article that a peg tube is merely a means to being able to provide food that is little more than any other physical assistance that an individual might provide to someone who is disabled and unable to feed themselves. And providing food through this peg tube, I have suggested, is part of our overall collective responsibility and responsibilities as individuals for those we care for within the framework of the duty to feed. And this is my suggestion, but again, this is something in which I'm still trying to understand this issue and seek more formal and more erudite opinions. I would also suggest that, consistent with Orthodox Judaism and most recently a fairly strong declaration within Catholicism, that this type of feeding is within the realm of basic care, a component of basic care that is consistent with the Islamic duty to feed and is not considered a medical treatment per se. As such, we should be putting in feeding tubes in those individuals with advanced dementia if we do not believe they will either prolong life or hasten death. However, there are several challenges to this paradigm that I am proposing, and these issues I throw out to the audience and to experts that I'm still trying to struggle with and resolve. First, and these are not necessarily in any order, is the duty to feed within the Islamic context meant to deal with alleviating symptoms and alleviating some kind of perception of hunger or starvation and any associated suffering with that on a psychological level from short-term not eating, because when we all get hungry, we're not happy. And when we're fed, we're generally happy and sleepy and, you know, all of that. You all know, you've just had lunch. Or is it a more physiological issue that you can actually measure the caloric losses, the chronic malnutrition, the sarcopenia, the negative nitrogen balance, all those things that lead to poor wound healing, impaired immunity, and all the sufferings associated with malnutrition on a physiologic level? It's not yet clear to me, and that's something I'm struggling with because that has impacts on the ethics of advanced dementia and feeding. Do all of these schools of thought within this non-monolithic institution of Islam agree on this? I haven't seen formal approaches that have been promulgated by any of the major Islamic ethical committees, whether in North America, in the Middle East, or elsewhere so far. If I've missed them, I apologize. I'm still searching. I haven't seen a formal response. And so whether the schools of thought, whether within Shia or Sunni or other madhahib, agree or not is uncertain. Whether they will agree with time, I'm not sure. There may be significant differences of opinion based on what literature we draw from the primary and secondary sources. The third issue is that even if we agree that we should be inserting feeding tubes within the context of advanced dementia, how does resource allocation fit into this? And this is something that, for example, if you have a fixed budget, which we all do, nobody has an infinite budget, and you can instead prolong life, or you can preserve life, or decrease disability, are those things prioritized on a higher level than just feeding? And how do we resolve that, if we had to? And how do we attach a quality-adjusted life expectancy or cost per life expectancy, that kind of rubric that is popular within modern resource allocation discussions? And finally, in many patients with advanced dementia, things become complicated. I can stick in the feeding tube, not me personally, although you wouldn't want me to do it. I have colleagues who will do it for me very easily. But then the patient with advanced dementia may become irritated, agitated. They may pull at their tubes. I deal with this daily. Sometimes you have to give them chemical sedation to decrease their agitation. Sometimes you have to tie them down to stop them from pulling out tubes. Does the need to feed and our duty extend so far as to restrain patients with either medications or physically in order to be able to feed them? I don't know, and this is an issue that I think is worthy of further discussion, and I look forward to your input. There are also scientific challenges. I'm almost done, Mr. Moderator. The first is, what exactly is starvation? And I mean not starvation within a purely scientific context, but giving the scientific explanation in order to understand the Islamic conceptualization of what is starvation, and because many ayat in Quran and the Hadith refer to making sure that people do not go to bed hungry, people are not starving, people do not have lack of resources. Is it a short-term thing? Is it something over hours or days, weeks or months? And does science have an answer that can help to decide on the ethics or not? And this is something I'm still struggling with. And finally, the major issue that remains to be resolved with an advanced dementia, and I don't know if it frankly ever will be, do feeding tubes and these forms of providing food and drink through artificial tubes, do they actually prolong life or not? Will we ever get a high-quality randomized or non-randomized study that will answer the question? If we do, we will certainly be able to inform the ethics side of it. I fear we never will. Thank you.
My thanks to our three speakers for very good discussion of their topics. Let me now make a few comments on each of these presentations. Imran addressed the important topic of cultural competency in physician relationship with the Muslim patient and its effect on the quality of care. Now, my comments come from my vantage point of being a practicing physician, and I deal with these issues almost on a daily basis. At the outset, I want to reiterate two important things Imran mentioned. One is the definition of cultural competency. Cultural competency is the ability of the physician to transcend differences in culture, language, beliefs, and values in patient-physician relationship. The second important issue is the concept that healthcare should be right for all people and not a privilege for only those who can afford it. The guiding principle in the practice of medicine is that the physician should give competent and compassionate care for all patients. Critical to the accomplishment of this goal is the establishment of an honest, respectful, and truthful physician-patient relationship. And this can only be achieved when there is a good communication between patient and the physician. The physician, a good physician, is a patient-attentive listener to his patient. This way, the physician can establish that important relationship which will translate into a good and compassionate medical care. Now, by virtue of its nature, its basic tenets, and day-to-day practices, Islam looms large in the makeup, in the cultural makeup of people. This will become clear if you glance at the 1.3 billion Muslims spread all over the world. Now, these are people with quite different cultural values and characteristic, but one thing that binds them together deeply is the effect of their faith on their cultural makeup. In many ways, Islam has established a way of life and a code of conducts and ethics for people as individuals and communities as a whole. Religion is a very important, but not the only determinant of people's personal values and how they react to illnesses and how they interact with their physician. Cultural and social and family values are the other important determinants. And this is where cultural competency and sensitivity on the part of the physician become an important issue in determining the quality of care patients receive. The point that should be emphasized is that here in the United States, we live in a pluralistic, diverse society, And we are people of different background, different values, different culture, and religious beliefs. Cultural competency, then cultural competency and sensitivity becomes an important issue for the practice of medicine for all people. It's not only the Muslim community that we're talking about. When we teach cultural competency and try to make our trainee and student understand that we really are talking about all segments of society and not one segment or one ethnic group. Now, of course, it is impossible to educate our student or our trainee to be culturally sensitive and informed about all ethnic and religious groups. But what we try to do as educator is to implant in the mind of our trainee and students that cultural competency and sensitivity is essential for the competent and compassionate practice of medicine. And in closing these comments, I would like to reiterate the guiding principles of bioethics: autonomy, non-malfeasance, beneficence, and justice. These principles require cultural competency and sensitivity as a basic necessity for their implementation. Dr. Faiz Khan discussed faith and care of the patient and Islamic perspective on critical illness and death. Reaction to a serious, life-threatening illness or imminent death varies widely. Personal and cultural values, educational and religious beliefs, or the lack of them, play a major role in this process. Islam, which provides its believers with a comprehensive look at health, life, and death, plays a big role in how Muslims react to serious illnesses, death, and dying. How does a Muslim deal with the avalanche of emotions that invariably come with the realization that life will end shortly, and with the pain and suffering that are often present at the end of life? Is there anything in the teaching of Islam that makes its followers behave differently from other people? Now, I have had a long career practicing hematology where I see death and dying not infrequently. My observations is that people diagnosed with an imminently fatal illness, regardless of their religious beliefs, go through the well-observed stages of shock, denial, anger, depression, and finally resignation and acceptance. This varies widely. Some individuals will linger in one stage or the other for a long time or all the way to the very end. Islam teaches its believers that life on earth is but a journey to a better world ordained by the Creator, who is merciful and beneficent, and that there is a day of judgment where and when the virtuous will be rewarded, the sinners will be punished. So in this regard, Islam is similar to the other two monolithic religions, Christianity and Judaism. A true believer in Islam will come to the end of life with a good measure of serenity and solace. For those who are faithful believers, the quality of life at the end of life is usually good, and to some extent they are spared the torment and suffering at the end of life. I have witnessed this firsthand as I watched my father battle and die of cancer. He was very serene. He really did not suffer as much as I have seen. But I have seen the same reaction in religious Jewish patient and Christian patient who also believe that life on earth is but a transition to another serene life afterlife. Other very important determinants of how Muslims or people in general react to an imminently fatal illness is their cultural and societal values. And again, when you look at over a billion Muslims spread all over the world, these are very different people in terms of ethics, their ethical beliefs, their societal values, but their religion has imparted on them some deeply rooted values. Islam teaches its believers to be very caring and protective of parents, family, and also neighbors. There are many verses to that effect, repeated over and over in the Quran. In many parts of the Muslim world, these are still tightly held and practiced values. And again, I have witnessed that in practicing medicine for 5 years in Iraq. These strong family and community bonds are still effective in making suffering of a serious illness and death and dying more bearable. Such suffering in these communities with these values, when it is shared and when there is family support and community support, one's suffering at the end of life becomes a family and a community affair, and thus it becomes much more bearable there. What is a physician's role when he or she deals or take care of an imminently fatal disease? As a doctor, the doctor tries to cure or stabilize a serious illness, whichever possible. But the doctor is always obligated to ease pain and suffering any which way possible. The doctor is required to ease physical as well as emotional suffering, and the doctor will provide the physical side of medicine plus emotional and spiritual support to the patient and the family using a non-denominational languages and expression with due respect to the patient's own beliefs, even if they contradict with the doctor's own thinking and beliefs. In taking care of a patient, the doctor is neither a priest nor a moral judge of his patient. In his written text, Dr. Khan addressed the issue of secular humanism. I don't see secular humanism, however one defines it, as an impediment to the physician's obligation to provide a seriously sick patient with the emotional and spiritual support they need. Whatever the physician's own beliefs, the physician has the obligation to give total and complete care, physical as well as emotional. And in teaching and training our student, we should firmly establish the concept of total care without any specific religious indoctrination. Dr. Alibhai discussed artificial nutrition in advanced dementia, scientific challenges, and proposed Islamic ethical response. First, Dr. Alibhai defines dementia, Alzheimer's disease being the most common type, and he described the prevalence and the devastating consequences of this problem. Dementia is a real problem in medicine, and it's going to get only worse because it afflicts the elderly, which is a rapidly increasing segment of our society. As of now, we have no effective preventive or therapeutic measures, and eventually the helpless victim loses all the faculties that define one as a functional human being. In the advanced stages of dementia, the patient becomes totally dependent for everything, even the simple act of feeding oneself. How much the patient suffers, we cannot tell for sure, but there is no doubt about the family's suffering. And here is where we face a difficult dilemma for which there is no good answer, as Dr. Alibhai discussed. What should we do when a patient reaches that stage of dementia where they cannot do anything for themselves? Should we feed them artificially because it is our duty to feed the hungry and to alleviate pain and suffering? Is that what we should do? Or are we just relieving really not a real suffering, but a perceived suffering? We really do not know what the terminally demented patient thinks. And Dr. Ali Bhai also discussed the pros and cons of putting a tube in the stomach, the benefits as well as the side effects. Now, what do we accomplish when we do that? Are we prolonging life or prolonging suffering? And then there is also the question of human dignity. Who wants to be in that kind of state, totally dependent on others for everything? But then, who is to judge the quality of life and what life is worth living and what life is not? And the recent uproar about the Shabbir case, makes that point. How do you say this life is not worth living or it is sacred, or life is sacred? The sanctity of life dictates that life should be prolonged all the way. I'm afraid there is no good answer to these questions. And as Dr. Alibhai mentioned, there is very scant scientific data for us to go by. Now, leaving the scientific data aside, what does Islam say about these questions? And are there guidelines in the Quran or in the words or deed of the Prophet Muhammad about such issues? Again, here, beyond the clear admonition regarding the sanctity of life and our duty to help the sick and alleviate their suffering any which way possible, we really have no guideline. Beyond that concept that life is sacred, we have no guidelines as what to do. When I ponder all aspects of this difficult problem myself, and I have gone through this, I look at the medical issues, I look at the patient, I look at the family, I try to examine all issues. I discuss them very clearly with the family, whoever is a surrogate decision maker. The family often looks up to us to advise them what may be the best course of action. And here is where I turn to my conscience and my basic moral values to decide what is in the best interest of the patient, where to go from there, how should we do it. I believe myself and my fellow physicians will look at every case individually, try to look at all issues and make the best decision that would satisfy our conscience and the will of our Creator. I think this is all I have to say about this presentation. Again, I thank you, gentlemen, for excellent review of your topics. We have time for a question. We have plenty of time. Yes, ma'am.
Mumina Kowalski, Hartford Seminary. As a Muslim chaplain, I was very excited to hear Dr. Khan and Dr. Punekar to mention this professional area of ethics. And I want to basically plug this whole profession in a world where, I don't know, when I go to the doctor, I see him for about 2 minutes. So, the profession of chaplains is one where we actually learn how to listen, and we actually get trained in all of these areas, specifically medical chaplains, and Muslim chaplains is really a hot new field in the United States today. And trying to educate people about what Muslim chaplains are is no small task. I think we're much more appreciated by non-Muslims than by the Muslim community itself. So I just want to plug for all the doctors in this room and everybody who is in any way, in any capacity of hospitals, able to influence the education and the support of Muslim chaplains and hiring Muslim chaplains, because this will be the area which will supplement many of these problems, just as chaplains, Jewish chaplains or Catholic or Christian chaplains do already. We help clinicians in hospitals, and I happen to be in prison chaplaincy, but I also will speak to our brand new Islamic Leadership Development Council from ISNA. We had our first Muslim Chaplains Conference in Chicago preceding the large annual ISNA conference last August, and we are now planning our second annual Muslim Chaplains Conference. And we actually have taken upon the task of not only including health, hospital chaplains, military chaplains, prison chaplains, and educational institution chaplains. So if any of you have lots of resources to spare, we need to help young people become Muslim chaplains. It's not the doctor engineer track for you know, a lot of people want their kids to go into these certain educational tracks to get the best salaries, but it is an absolutely necessary and needed face of Islam in America today. Thank you.
Thank you.
Thank you. Dr. Shabbir mentioned that definition of starvation. Obviously, we know the definition. Let's not talk about the biochemical or scientific definition, but from a social and religious point of view, it's obviously the deprivation of food. Let's talk about, we're not talking about the deprivation as a result of poverty, because you mentioned the hadith that's related to poverty. But if we were to consider the deprivation of food, let's say for the baby, and then the mother could not feed the baby, then obviously there is here the mother's milk, the other a woman comes step in and feed the baby. And if we just try to extrapolate on that, you have a mentally retarded child, or you have advanced dementic patient, and what to do is that really they are incapacitated, so you would have to actually support them by feeding them. And I don't see any really a line to draw here to withdraw food. But of course, this is a fate that you are faced with. So you just leave it to fate. And this it could be a father or mother who served you when you were actually incapacitated when you were born. So might as well leave it to, I think this is my own interpretation. You try to do your best, but it is very hard to withdraw because of silly things like whether just to end the life. And I think it's just leave it in the hands of God. If they were meant to destined to die, we are all destined to die anyway. Thanks.
Shabbir?
I thank you for that comment. I completely concur with you. My own feeling is the same when I met with these situations. In the larger artificial nutrition and hydration literature, there are two responses to that have come up over and over again. And you know, we could talk about all the arguments back and forth, but generally, the people who don't agree with that position will give at least one or two arguments. The first is that you're not dealing with a situation where the person is likely to have benefit in a physiological sense in terms of prolonging survival. If there is an infant who cannot feed and you feed that infant, they are almost certainly going to live longer than if you don't feed them. That's just, you know, a non-entity. The notion of individuals who are physically or mentally challenged who cannot feed themselves, you feed them, they will live longer. People who have a stroke and can no longer feed themselves, you feed them, they'll live longer. There's evidence, whatever level, for those. In advanced dementia, the difference that some will point out, not all, but some will point out, is that even if you feed them more aggressively, the weak studies that have been done to date suggest they don't live longer. And one of the arguments is, what benefit are we giving them if we're not able to help them live longer? That's one response. And of course, your counterpoint would be that it's not just about life, it's also about sort of our basic duty. The other response that people will give is, nobody's stopping us from feeding them, but what they're doing with the artificial liquids and the tubes and so on is no longer feeding, it is now treatment. And that's the other argument that people make, that would Islamic bioethics consider this to be treatment or just food and drink given a different way. I'm suggesting the latter. I think you're suggesting the latter. Some people are arguing it's not and it is different. And that's what I'm looking for from experts and other colleagues as to which direction should we be thinking about this? Because like you, I see it as the latter rather than the former, but I'm not sure if everyone here does.
To continue on the same topic, Dr. Alibhai, if I understood you correctly, you were looking to see if there are sources, Muslim sources you can go to on this. IOMS has had a great number of discussions on this. Hassan Hathout has written on this topic, and you may want to look that up. You know, we're talking of scientific challenges and Islamic ethical response. There's another element to feeding. Feeding somebody, it's symbolic of a lot of things. So even if you were to put everything else away, it's not just an issue of making the patient live longer. That patient, unless the patient is in a nursing home, is part of a family. So the feeding aspect of it, it's symbolic of the care of the family. And this is not just for Muslim families. And therefore, I think we're missing a very major issue when we talk of the science, does it prolong life or not? And when we talk of the issue of, well, what does fiqh have to say, or is there a religious opinion? There's another element, which is the psychological element of that family where this patient is located. And I think that has to be, feeding is symbolic. The other thing, Dr. Imran, I enjoyed your presentation. Cultural competency has always confused me. I do not understand what that means. For example, I mean, one of your cases that you had, which was, I guess, somebody who had cancer. And the question was, would you want to know? This is not an issue just with Muslims. If you've looked at Leslie Blackhall's study, which was done in the States, and it was done on South Korean, Chinese, and Afro-Americans, and if you look at that, there's a tremendous variation in that. So I don't know how one makes somebody culturally competent except to focus on some of the basic things that I think Dr. al-Mondhiry talked about, which is the issue of basic compassion, listening to patients, looking at each individual differently, and finding the time to do it. So.
Thank you for that comment. I just wanted to respond really briefly and say that as far as cultural competence goes, what it's really all about is making sure that you're providing care and overcoming barriers which might be present with certain populations of patients. And for instance, in the whole issue of truth-telling, it's true that it's something that's common, or withholding the truth or withholding diagnosis of cancer is something that's common and it's present across the world. However, it's also true that it's also more common in certain areas and within certain cultures. And that includes Middle Eastern or Muslim cultures or Eastern, Southeastern Asian cultures. And so in that sense, the physician needs to know that when he's going into an encounter with a patient or a family from that region, that this could be an issue and that this is something he needs to be sensitive to and make sure that he's still able to maintain the obligations of his patient-physician relationship.
Just one comment about the truth in physician-patient relationship. There is a big cultural element in it. Here in the United States, there is no question when we diagnose a serious illness that we have to make the patient understand. If the patient cannot understand, the family should understand. In other parts of the world, you know, again, I encounter that in my own practice. For example, in Iraq, I would diagnose a patient with a very serious type of leukemia, which will not allow the patient to survive. The moment I say this is what is going on, members of the family will fall on me and begging me and trying to pressure me to not to say anything to the patient. And well, the justification they give is understandable, but I said, look, here is a human being, an intelligent human being like you and me. How are you going to go on from now on without telling this human being what's going to happen, and how am I going to treat with serious drugs that have side effects, without telling the patient what I'm doing, why I'm doing it. What I'm coming to is the duty of the physician to educate the family on the right way of doing things. I have resisted all the pressures from the mighty and the law and everyone to say, look, there is one way of practicing medicine correctly, humanely. You've got to make the patient understand. Of course, you can use language that the patient understands. You don't have to use complicated terminology. But we physicians have the duty to educate not only the patient, but the family, and to do the right thing for the patient, even if we are subjected to sometimes tremendous pressure to do the opposite.
Can I just make a quick comment on that?
Yes.
I'd like to just, one can accuse Dr. al-Mondhiry of being anthropomorphocentric. No, I'll tell you, it's very interesting. Most modernists don't realize this, but there's more to just buffering a patient's psychological trauma behind a family not wanting to tell them bad news. Okay, most traditional societies, and this has been already demonstrated with the Native American traditions, consider effectivity through words. If you tell someone, okay, the only reason why leukemia means anything is because of its prognostic significance, not because of its diagnostic significance, right? Everyone knows that. Certain things have buzzwords, okay? CHF, for instance, has a very poor prognosis, but no one really cares. If you've got CHF, you've got leukemia. Which one would you rather have? CHF, you wouldn't want leukemia.
Congestive heart failure.
I'm sorry, congestive heart failure, sorry. So, a lot of people believe that there's two reasons why people don't want to have their loved ones hear bad news. A, it's because of a psychological buffering, like don't tell them bad news, right? That's paternalism. But B, this, if you analyze this might be a mental reflex that's left over from understanding that a bad word is negatively efficacious. And at that point, you have to say, well, gee, what good is there in informing a patient prognosis? So that's just, it's an interesting way of looking at things.
The point here, I don't want to prolong this, that you have to embark on a treatment, and you cannot start treating a serious disease like leukemia or cancer and give the patient potentially, not potentially, you get lots of side effects. The person has to understand why you are doing this, and it will be cruel and incorrect and not justified by any religion or any social custom to subject the patient to treatment that the patient does not understand why. It is our duty to do that. We can do it gently. We can do it with, all the compassion we have, but we get to do it. We cannot neglect our duty in that regard.
If I may respond to your comment to me, Dr. Muazzam, because
I'm still on the first one.
you're actually, that was the second one. You first addressed me,
Oh, sorry.
then you addressed them. I haven't had a chance to respond yet, if I
Sorry
may.
about that.
No, that's all right. I'm certainly not trying to dehumanize the feeding discussion at all. And I know where you're coming from. I sense it the same way. It's a basic human dignity is the main argument I'm trying to make. However, we cannot ignore the science for two reasons. One, even though it seems very obvious to us that it's a very humane issue, and to think otherwise, as two of you have already said, it just seems unfathomable. There are thousands and thousands of people from a variety of cultures and ethnic backgrounds and different levels of religiosity who feel that to put in feeding tubes is inappropriate, it's barbaric, it's inhumane, and so on. And many of them are Muslims and Christians and Jews, and they share some traditions with us. So it doesn't seem to be universally held. So I'm trying to understand more about why. But also science informs us if, for example, we found that feeding tubes and the complications associated with the insertion of the tube, the artificial reflux and the risk of aspiration with contents of food going into the lungs and causing pneumonia, all those things shorten survival, that's an important scientific thing we would need to consider. So I'm not saying science is going to answer the question definitively for us, but science may provide information that's useful. It may not. But it certainly doesn't take away from the fact that this is first and foremost, as I see it, a humanistic issue, and I agree with you on that. That's my only comment.
May I? I'm sorry. Yeah, we can discuss this outside, Dr. Mondhiry, because I've practice for 50, those are fighting words? Okay. No, it's just to make a point based on my own experience. And this is 15 years in Pakistan and a similar number of years in the United States in practicing medicine. And in Pakistan, for example, the issue of cancer, when you see a patient, this is a patient who's lived with that family generally all his life or her life. And the family, if the family tells me that this is something, if you tell the person, if you tell my father that he has cancer, this is going to just totally demolish him. Now, having said that, I judge, and what I have found is it's not that that man does not know that he has cancer. You have to talk to him, obviously, because you're going to treat him. But there are certain words like cancer or leukemia, which in that setup is not mentioned, which is not to say that when that old man is having chemotherapy, he doesn't know that he has cancer. So that's the only point, and I don't want to believe it.
Just to glibly say, she's prioritizing psych over physio. He's prioritizing physio over psych, and that's essentially what it boils down to. And both are involved in healthcare.
Faiz, I'm not prioritizing one over the other. But what I'm saying, you cannot give competent state-of-the-art care with a patient not knowing what you're doing. Just use chemotherapy. What will you tell the patient? You have a common cold, I'm giving you cytotoxic drugs that are going to make you sick, that are going to make your hair fall off. No.
I have my own opinion about chemo.
You got to explain it to the patient in a way they understand, showing them the compassion. I have done that all the time. I may spend an hour just sitting there, explaining to the patient what it is that I'm doing. And I do that, and it always leads to a good outcome. I may not save the patient's life, but I will give them whatever left of their life, a more comfortable kind of life. You just cannot leave, no matter what other issues are, you've got to make the patient understand. You communicate with the patient. That's the theme that I'm coming back to over and over. I think there's a question in the back.
Yeah. Okay. Well, yes, I'm Bert Broekhaert, Leuven, Belgium. I have a few comments regarding the tube feeding issue. First of all, as far as the attitude of Catholicism is concerned, it was very strange to see that what the Pope said during the last months of his life regarding tube feeding was not in line at all with traditional Catholic thought about it. And for instance, to illustrate that, in Belgian hospitals, in which the majority of which are Catholic hospitals, there is as a general ethical rule, the idea that when confronted with advanced dementia, tube feeding will not be started. So it will not be started. So the general advice is in that line. And second, in most European countries, tube feeding or artificially feeding or hydrating patients is regarded as a medical act. And it's not equated with feeding or with eating or drinking as such. And then thirdly, I think what's important, and that's of course explains in a bit the difficulty of finding something in the sources, is the fact that this problem with tube feeding is of course a very recent problem, in the sense that it has to be treated in the line with all the discussions around futile treatment and so on. And all these discussions around futile treatment have to do with the advances made in medicine just in the last few decades.
And if I may quickly piggyback on that, we have a tendency here in this room to differentiate widely among different kinds of Muslim expressions, and yet I've heard now a couple of times the idea that Catholicism is authoritarian, but in fact it's a very rich tradition, and not every statement that comes from the Vatican is equally authoritative. And this very statement that both of you referenced is now under a great deal of debate and revision.
Yeah. The only other comment I'll make is I agree with those comments. They are uncontestable, and I have no need to contest them. There is much more more similarity, I would think, between the Islamic ethical positions on a number of issues and Orthodox Judaism than there is in Catholicism in a number of areas. There are some significant similarities, but there are more differences between Catholicism and Islam and Catholicism and Judaism than there are between Islam and Judaism. And the feeding issue, aside from the papal declaration recently, you're absolutely right. The Jewish position has been fairly consistent for a long time, at least in the Orthodoxy and their interpretation of halacha, that tube feeding is quite appropriate and necessary to institute in patients with advanced dementia.
Very enlightening talk and discussion. I have two questions, and one of them is going to be provocative for, I guess, all of us. The first thing is, Imran, you mentioned the term override culture in your third case presentation, meaning that the culture of the patient might need to be overridden by the medical culture that we bring. I don't understand how that's ethical, and where does the medical culture, why can't the patient's culture override the medical culture in that circumstance? And how far are we obligated using the principles of biomedical ethics to have distributive justice to meet those needs? So you can comment on that, and I'll say my second thing before you'll jump to answer. This is for Dr. Alibhai. You know, we spoke about feeding tubes. When I was many of you have had more clinical training than I've had, but when I was on my ICU rotation, I was given a paper about PEG tubes. It was either from Mass General or Johns Hopkins that showed that people who get feeding tubes have increased suffering, that their experience when they are not senile is not a good thing because you have to give them this medication, that the time that they spend, actually they suffer unless you sedate them totally. Hence, I'll rely on a principle from Kulliyat al-Sharia, la darar wa la darar, do not harm, and there's no harming, there's no recompensation for harm. So how does that play a context? And the provocative part of that is, you mentioned what kind of life is worth living. I'll play the advocate that if we say Islamically the purpose of life is liya'budun, as the Quran says, وَمَا خَلَقْتُ الْجِنَّ وَالْإِنسَ إِلَّا لِيَعْبُدُونَ, we have not created you, jinn and ins, except for to be in servitude to us. If a person is at that point that they are not aware of their surroundings, they cannot formally worship God or remember Him, they're in ghafla, not understanding who God is that life truly worth living?
Okay. To respond to Asim, your first comment about where you draw the line in overriding the patient's culture versus overriding the medical community's culture, I think one of the important things to remember is that the medical profession comes with a set of ideas about integrity, duties, and professionalism, and those are forced or formed, generally speaking, by the society that medical profession is engaged in. So, for instance, if you start seeing medical professionals who supposedly cater to both general sentiment in society, but also to a specific moral code that they've espoused, if you see them sort of going against that and providing care which contradicts some of their obligations or the integrity of the profession, then that'll build mistrust between not only individual patients, but also the general public and also the healthcare system. So I think where you can draw the line, however, is as far as overriding the culture of the patient versus the hospital or the healthcare institution, is it's okay to maybe accommodate for the culture of the patient and provide a service that is medically futile or has no direct benefit, but it benefits the patient and it respects their culture and who they are. But however, when they ask for a certain procedure or the lack of a procedure that directly translates into maleficence, or the lack of beneficence when it's mandated. I mean, for instance, the classical case of a Jehovah's Witness child coming in with their parents, and the parents asking that the child not receive blood transfusion because it's against their religion. I mean, you're legally mandated to provide a blood transfusion, regardless of what the opinion of the parents is, because their autonomy is out of the scope of the treatment of the child. So in that case, because you're legally mandated to be beneficent towards patients, you have to maintain that, and you would override the culture of the parents or who are the decision makers of the child.
Imran, thank you. I received an order from Jonathan to stop and adjourn this meeting. Thank you very much, gentlemen. Thank you for those of you who discussed this.
One request, if we could avoid use of the word